First with Dr. Rex. He's a true legend of GI. I think everyone here knows his name. He's a distinguished professor at emeritus at Indiana University School of Medicine and clinical faculty at Indiana University hospitals. His major research is in colorectal diseases, primarily colorectal cancer screening, in addition to techniques of colonoscopy. We all know that he's a big part of the research committee or community, and he's authored more than 300 original research papers, 70 book chapters, 230 invited papers, 75 editorials, and 40 guideline papers. He's chaired the U.S. Multi-Society Task Force between the years of 2000 and 2006, and again in between 2012 and 2018. He's been our president of the American College of Gastroenterology and our most recent past president of the ASGE, the American Society of Gastrointestinal Endoscopy. To say all this and to just tell you how much of an educator he is, this is the first time I get to meet Dr. Rex, yet I feel like I know him for like Mr. Rogers' Neighborhood, where you watch the videos over and over of my whole life education of everything we do. So it's a true honor to have him here. I'm also going to, and you can sit here, and then I'm also going to present, because right after him will be our DDW updates, and we also have, as everyone knows here, Dr. Fadi Antaki. His reputation is well known throughout the whole state of Michigan. He's a professor of medicine at Wayne State University, and then also the section chief at the John Deagle VA Medical Center in Detroit. He has a lot of medical expertise and GI expertise, especially in biliary disease and colorectal cancer screening, in high quality care and colonoscopy, and also taking out large polyps. So to tell you that Dr. Fadi Antaki I've known for several years professionally, but over the last couple of years through this society, I've really got to learn more about him as a friend. He's a humble leader and is always very insightful, so it's an honor to have him here too. If you want to come up, and he'll be giving us our DDW updates. So Dr. Rex, you can take it away.
Yeah, thank you. That was a really nice introduction, Mark, and it was really amazing because it didn't look like you were reading it. Usually people are reading it, you know, he did this and that, so that was pretty impressive. Thank you so much for the opportunity to be here, and thank you, Laith and Ava and Jamie, for the invitation. So I'm going to talk about doing colonoscopy in patients with difficult anatomy, and I want to just remind people about safety, because when we have a challenging colonoscopy, we don't want to take risks. You know, we don't want to have a perforation in these patients. I've never had a perforation in these patients. I think we're entering an era where we can go through many, many thousands of colonoscopies without having a perforation. So just to remind you about the basic rules. One of them is don't push against fixed resistance. I think true fixed resistance in the colon is extremely rare. It happens mostly in patients who have had extensive pelvic surgery and often radiation. Most of the time when people talk about resistance, they just have too big a loop in the colon and they can't stretch it out anymore. So, you know, back off. Sometimes when you have true fixed resistance, you can overcome it by using a thinner scope. But the rule of don't push when you feel that the scope won't go in anymore is still a useful one to keep from breaking out the sigmoid colon. Second one is barotrauma. So barotrauma perforations, a lot of people have never seen one. I hope you never do. They're the worst perforations that occur in the colon. Patients often become septic very quickly, partly because the prep is often bad, and they can develop compartment syndrome. So they can literally tank in front of your eyes. And the reason I know this is that I review medical legal cases, and it's they're often very bad outcomes when there's a barotrauma perforation. So the rules of barotrauma are, first of all, that barotrauma occurs only, absolutely only, in patients who have bad, nasty sigmoid colons. That's the only group of patients that get it. So what happens on the left there, where you have a normal sigmoid colon and you're pumping gas in, that gas can come back around the scope and come out the anus. But if there's a lot of diverticular disease in the sigmoid and you're pumping gas, that gas may not be able to come back around the scope. And if the ileocecal valve is competent and won't let gas back up in the small bowel, you can very quickly get a closed compartment. The proximal colon will get distended, you get serosal tears, and then perforation. And the problem is, by the time you get to the proximal colon, it's already happened. It's too late. You can't prevent it anymore. So the way to prevent it is to anticipate it. And that means that every time you go into a really bad sigmoid colon, you stop pumping gas. CO2, I've had one in my career and a fellow insertion, happened with CO2. CO2 is a gas and it can distend the colon. So CO2 is not protection. You got to switch to water because water won't make it happen. And then the third thing is avoiding splenic injury. So we have probably in the US, according to the most recent estimates, about 1 splenic injury per 6,000 patients. The only really clear risk factor is a female patient. About 75% of the reported cases are in females. And we don't have a rule for how to prevent it, but my own recommendation is that once you get the tip up proximal to the splenic flexure, you need to be very careful about the forces that you exert on those ligaments that connect the spleen to the splenic flexure. So pulling hard, twisting hard, all those things are things that you have to try to avoid. If you've got a big loop in and you're unwinding it, you want to unwind it gradually and constantly be thinking about that connection between the spleen and the colon, especially in thin women. Okay, so performing difficult colonoscopy. So the things I'm going to recommend to you are based on my own experience, which is more than 1,100 patients, all of whom were referred to me for prior incomplete colonoscopy. That's actually more than half of the published literature. So I have by far the world's largest experience with this. Have a 97.3% cecal intubation rate in this group of patients without the use of balloon enteroscopes. I know there are people who feel that balloon enteroscopy is the solution to previous incomplete colonoscopy. But actually, if you look across the literature, their success rate is about 95% in this population of patients. So the things I'm going to tell you about are things that you can do with your standard set of instruments that you have without the use of balloon enteroscopes. Now, we often, when we have an incomplete colonoscopy, we send the patient for a radiographic study, and, preferably CT colonography, but it could be barium enema because CT colonography is not always available. And I'm just telling you that if your goal is to look for polyps, that has a very low sensitivity. And it's partly because the same bad anatomy that is keeping you from getting to the cecum is going to cause them to have a lousy quality study. Okay? They're going to have a hard time filling the colon if the sigmoid is really bad, or if the colon is really redundant, they're going to have a hard time getting parts of the colon distended. So we generally tell people, I tell my partners, referring physicians, that if you have an incomplete colonoscopy, the best thing is either try it again yourself or send it to an expert center. These are some of our publications on prior incomplete colonoscopy, and I want to focus on this bottom one. So this is patients who have been referred somewhere after an incomplete colonoscopy. They get a CT colonography or a barium enema, then they come to us and we complete the colonoscopy. So this is the per patient and per polyp sensitivity of CTC and barium enema in this population, and I'm telling you, it doesn't matter how big the polyp is. 10 to 20 millimeter polyps, 20 millimeter and larger polyps, they miss almost all of them. I've only had one cancer referred, that was missed also. So that's the rationale for considering a repeat colonoscopy. Okay, so the approach that I take is, first thing you're going to do is classify the anatomic problem. You're either going to classify it based on your own experience, or if somebody's referred it to you, that's the situation for me. I just look at the previous report and I classify it into one of 3 groups: redundant colon, narrowed or angulated sigmoid, or hernias. Okay, so hernias are the least frequent indication, but they're a real problem. Left inguinal hernias, they're not the problem. A left inguinal hernia, if you roll the patient on the back, you can almost always get that hernia back, that bowel back into the abdominal cavity. But transverse colon hernias are very difficult. So if you have a patient with a great big abdominal wall defect, a whole bunch of transverse colon out in that hernia, even with them lying on their back, it's very hard to push that colon back into the abdominal cavity. And when you get up to a hernia, anytime you're entering a hernia, and just in general, anytime you encounter a really narrowed section of the bowel, maybe you got a twist on it, the first thing ought to cross your mind is, am I in a hernia? Reach over the patient, start feeling around, because in case the scope's going out into a hernia that's, in the scrotum, you want to know about that right away. But what you can usually do with a hernia is you can get into the herniated bowel, but you can't get back out the other side. And this is true with transverse colon hernias also. And I've seen some where the only way colonoscopy could be completed is to have the thing surgically fixed. And sometimes, nobody wants to fix these patients. They're often very, very heavy, very high BMIs. Okay, so the great majority of the cases, it's either a redundant colon or it's a narrowed and angulated sigmoid. Redundant colons, the patients often have a very high BMI, but sometimes it's just a normal variant. The general approach here is we're going to use a standard scope, not a pediatric scope. I see fellows, a lot of people, the first thing they think in a difficult colonoscopy is, I'm going to use a pediatric scope. But that's not the best scope to use in a redundant colon because it's floppier. It's going to loop more. An adult standard scope, water immersion, occasionally you're going to need an overtube. And then for the narrowed angulated sigmoid, you need a skinnier scope. Sometimes you need a skinnier scope plus a short bending section, and again, water immersion. So again, just to point out the scopes, it's easy for a redundant colon. You're going to use an adult scope. But for a narrowed angulated sigmoid, start with a pediatric scope. If that fails, you're going to go to an ultra slim colonoscope. Does everybody have an ultra slim in their unit? If you don't have one and you do a fair number of older patients with difficult sigmoids, they're nice scopes to have. They're colonoscopes. They have the length of a colonoscope, the same length of a bending section on the end, but they're the diameter of an upper endoscope. And then sometimes you need a scope with a short bending section because it has a really tight turning radius on it for going through an angulated sigmoid. So why water? Well, the problem with gas in a really redundant colon is that as you're pumping gas in, you're making the colon longer. I tell people it's just like a clown with a balloon. As you're blowing that thing in, it's getting longer as you're pumping it up with gas. And so this is how you get to the hepatic flexure, you get to the mid-ascending colon, you're just out of scope and you can't find a way to recover. So you start off with water. If you're in the middle of the case, you can come out, suck the gas out, and start over with water if you want to try it right in the middle of the same case. But this will keep the colon shorter, and it'll keep the sigmoid colon, which has, the sigmoid colon and the transverse are both on a mesentery, right? They're the two longest sections of the colon. So when you pump the colon with gas, the sigmoid moves into the mid-abdomen, it gets longer and wider, and you're using up more scope with each loop that you pass. So you fill it with water, it lies down straight in the left lower quadrant if the patient's in the left lateral decubitus position, and you get over to the right colon, and now you've got enough scope left that you can get down into the cecum. In the sigmoid colon, the really bad angulated sigmoid colon from diverticular disease, water, as you recall, helps, it will prevent barotrauma. And then secondly, same thing, it'll make the sigmoid lie down in a straight line. So here on the left is the pediatric colonoscope, and then an upper endoscope, the ultra thin colonoscope, and an enteroscope, the SIF enteroscope. And you can see that all three of the scopes on the right are in the 9.2 to 9.5 millimeter diameter range. But you remember, when you just go down a couple of millimeters in diameter, what really matters is the surface area, pi r squared, the surface area. So you have a pretty significant drop in the diameter of the scope. So that's part of what allows these scopes to pass the sigmoid colon. The other part is the length of the bending section. So on the left is a pediatric colonoscope and the ultra-thin colonoscope. They've got a longer bending section. It has a wider turning radius than on the right, an upper endoscope and an SIF enteroscope, which have a very short bending section and therefore a very tight turning radius. And there are absolutely times where that's critical to get through an extreme angulation in the sigmoid colon. The other thing that's important is to be able to optimize steering. So this is the way that I do it. I push the insertion tube in with my right hand like everybody does, but when you're going around very short bends, you need to operate both the up-down control and the right-left control simultaneously with really exquisite control. And I find the best way to do that is to drop the insertion tube between my fourth and fifth fingers of my left hand. We call that the left hand scope grip. And then you can push the scope forward or pull it back over short distances, keep pressure on a turn, and at the same time operate the up, down, and right, left control with maximum. If you could start that video for me, please. With maximum control. So here's what it looks like outside the patient. You can put torque on the instrument if you want to. That's nice for therapeutics. And then once you've done this, once you've got it pinned, your right hand is now free to operate the right-left control while your left hand operates the up-down control. If you could start that video. So this is what it looks like in an angulated sigmoid. So you can see I've got the insertion tube, very thin insertion tube between the 4th and 5th fingers of my left hand. I can take my right hand off and push in a little bit. The key, I have never found a bad sigmoid colon I couldn't get through if I had the right scope and we're underwater here and we take our time. And the critical thing is to go slowly, make very slow movements. Identify the lumen and then push your way into it. Sometimes we're pushing our way in. Here you can, I don't even know where the lumen is at this stage. So just like we always do, we back off very slowly and look around until we find it. And then once we find it, we've got to keep that forward pressure into that bend. I still, at this stage, don't know where it is. Now, this is actually an enteroscope, and again, the advantage here of this enteroscope, because I'd previously tried an ultra-thin in this patient. There's the lumen. Now, we've got to keep a little bit of forward pressure, making very slow movements, not losing track of where that is, and just work our way through there. But the key is patience, excellent tip control, and being able to keep constant forward pressure toward the direction of the lumen. Once you get through, you'll know it, because all of a sudden you pop into open colon, and then it's going to be a free ride to the cecum. It's a very different experience than the redundant colon. These patients, the cause of this is almost always bad diverticular disease. And now you can see we're in the clear. Okay, so the redundant colon. So what are you going to rely on in a redundant colon? Well, the first thing always is loop reduction, right? That's the fundamental feature of good colonoscopy, is that you recognize that there's a loop in the colon and you take it out. And the fellows sometimes ask me, when do you start taking the loops out? And the answer is as soon as you're making them. You want to get the loops out as soon as you can. So that's critical. Then the choice, I think, is between abdominal pressure and position change. And if you look at these scope guide studies, the magnetic electronic imager studies, they actually suggest that position change is more effective than abdominal pressure. And I will tell you that I've almost abandoned position change. And the reason is that we have everybody basically in general anesthesia, right? Because we're using the anesthesiologist giving people propofol. And I find, especially when you rotate them on their back, or if you rotate them on their right side, too many of them will reflux during the procedure and start coughing. So I tend to keep them on their left side and use more pressure. I don't pay attention to loops. I know people talk about loops, alpha loops and N loops and so on. I think they're interesting, but because I don't use scope guide and I don't use fluoroscopy, I can't see the loops. So I think the critical thing, probably the critical thing of good insertion technique in general, is to recognize that you have a loop anytime you don't have good one-to-one transmission. And then to unwind the loop, whether you're going to unwind counterclockwise or clockwise, it's a matter of feel, right? You have to learn to feel as you start to unwind it in one direction. You should be able to almost instantly feel if it's the right direction. Is the loop starting to unwind, or is it becoming tighter? If it's becoming tighter, you go the other way. No doubt occasionally you have to push through a loop, just like sometimes you have to push through, you have to slide by. I hear people sometimes say you should never slide by, and I can't imagine not being able to do colonoscopy without having to occasionally slide by. Abdominal pressure, I think, is an art. We all know there are some techs that are better at it than others. I like for the techs to be able to see a monitor that's behind me when they're pushing. Remember, the best use of abdominal pressure is to prevent loops from forming. And so if you get a loop early, even though you still got a lot of scope left outside the patient, sometimes it's good to get pressure on, take the loop out, get pressure, and try to prevent the loop from reforming. Remember, after you've passed a loop, it's often helpful to take the pressure off. No question that abdominal pressure can prevent forward movement of the scope. It may help for one phase, and then for the next loop, it may actually be countering forward movement of the scope. People often have a tendency to push directly posteriorly, but oftentimes the best way to push is both posteriorly and in a second direction. Remember to only try each place once, and if you feel the loop in a specific spot, pull the loop out and then put pressure on that specific spot. So for passing the sigmoid, I often see people pushing in the left lower quadrant, but the best place to push is in the right lower quadrant back toward the midline, because remember the sigmoid is mobile, it's often moving up into the right quadrant. To cross the transverse colon, to push from the left up in the splenic area, the patient's in the left lateral decubitus position to almost lift it from the left flank upward. To counter transverse loops, 2 hands in the lower abdomen pushing up, and then to move from the mid-right colon down into the cecum, oftentimes right flank pressure or lifting up on the cecum is helpful. The floppier the scope is, the more likely you're going to need pressure. In these very redundant colons, I will tell you that when we're really stuck, I really make it clear to the people that are pushing that I can't get to the cecum without your help. It's going to be you getting to the cecum, and we got to figure this out. We got to try enough things. We'll get 2 people. Really high BMI patients will sometimes get 3 people, 6 hands on the abdomen. And sometimes we're literally massaging or kneading the abdomen, trying to catch the side of a scope and get the loop to get the tip to move forward. And you don't want to do it too fast. You want to be able to sort of, if people are kneading and moving around, you want to be able to see if something's working, communicate really clearly. So somebody makes a move that gets the scope tip to jump, go, great, that's the right spot, stay there as we go forward. If you do use position change, left lateral decubitus, I typically start there. There are literatures on starting supine or prone. In terms of changes to cross the transverse, the classic thing is to rotate supine. And I always thought when we used moderate sedation that the single most consistently effective position change was to go from supine to right lateral decubitus to move from the cecum from the ascending colon down into the cecum. But again, don't use it very much anymore because everybody's deeply sedated. So if in occasional redundant colons, you are going to need an overtube. And the black overtube there is an old Olympus overtube. They don't sell anymore. And the white one is the Neptune, the Pathfinder. This is a new overtube that's pretty easy to use. I usually use this to launch an enteroscope. So I go in a redundant colon with a standard scope, work at it really hard. I can't get there, go back up with the Pathfinder on the standard endoscope, and then pull it out and put an enteroscope through it for additional length. Then finally, be sure you record the methods that you use to achieve cecal intubation, because the same anatomic features that were a problem the last time are going to be there the next time. That's the biggest problem with getting these referrals is they come back to you, for their next colonoscopy. And so you go straight to the method immediately that got you there the last time, because the great majority of the time it will work again. So to summarize, classify the anatomic problem. Is it a redundant colon or a bad sigmoid? Choose the right scope. Go in underwater from the get-go. Use basic good technique in terms of withdrawal. Have a way to optimize your steering. If your hands won't do that, I think there's nothing wrong with having somebody hold the scope, keep some pressure forward, have an assistant do that. For redundant colons, use pressure liberally, and then have an overtube available, but nobody likes to use them. So hopefully, if you use the right techniques, that need for that will be infrequent. Okay, thank you very much.
Okay, so good morning, everyone. Thank you for coming here so early today, and I can't believe we're doing it again. So last year was our first inaugural annual, and we thought if it works out, we'll do it again. Well, here we are, and hopefully we'll do it next year and every year afterwards. And thank you for inviting me to speak today. It's an honor to be here with Dr. Rex and Dr. Piper. Before we start, I have a little anecdote. I'm reviewing a paper for endoscopy from England. We do things, we think like we know what we're doing here, right? In the US, we're the best of the best. And you read a paper from England, they do colonoscopy with like one over said, the patients change position 6 times on the way in and 5 times on the way out. And somehow they get to the cecum like every single time.
question is, are they willing to come back for another colonoscopy?
Yeah, that's always the interesting question, right? Okay, so I was asked to speak about DDW abstract related to colon, but I'm going to start with an abstract. So anyone who's been DDW registered for it, you should have access online. I highly recommend the AGA presidential plenary session. Really great session, but there's 2 medical history talks, and I'm going to mention one of them because we're in Traverse City, and we're about 100 miles away from Mackinac Island. If you've never been there, magical place. Horses, the smell of horse manure, bicycles, the whole thing. But Dr. Beaumont, whose name got recently canceled in Southeast Michigan, almost, was there, right? And he is the guy who discovered gastric physiology by experimenting on the gastrocutaneous fistula of a guy who by mistake shot himself in the abdomen and survived, and did experiments for about 13 years. So, you know, if you ever go to visit there, or if you get a chance to watch that AGA plenary session, I think you'll learn quite a bit about how our field got to life. So the first abstract that I'm going to present to you that I found kind of interesting is one about AI, or CAD-E. So obviously, we have state-of-the-art talk about it tomorrow, and hopefully this will explain to us how AI fits in our practice. But this one study, they compared CAD-E versus conventional colonoscopy for screen colonoscopy. What they looked at was adenoma per colonoscopy, and when you call it positive predictive value, meaning number of adenomas divided by total number of polyps, because the fear is always we're going to catch a lot of hyperplastic polyps and waste our time. That over 1,000 participants. This is a new system that's not on the market yet. And obviously, as we kind of expected, they found more adenomas per colonoscopy in the group that used CAD-E, and the positive predictive value did not go down by a whole lot. They also found a slight but not significant improvement in ADR, advanced adenomas, cell-ulcerated polyps, and a small 1-minute increase in withdrawal time. So really no statistical significant changes, anything else, but more adenomas per colonoscopy. So you think, well, you know, everyone's saying this. AI is great. It works fine. Every study in the last few years has been positive. And they concluded that we should be all using it. Well, then I saw this other abstract. So that's why it's getting confusing, and that's why I'm so excited about state-of-the-art talk tomorrow. Well, this study here, they deployed AI, or CAD-E, at 5 of their centers. And then they had other centers that did not get CAD-E, and they looked before and after they started using the artificial intelligence system. Also, another 1,000 colonoscopies. Pre-implementation of AI, they did pretty good. Their ADR was about 42%. Their withdrawal time was about 18 minutes, which is pretty long. Found a lot of serrated polyps, a lot of advanced adenomas. And when they implemented the CAD-E, as you can see in the top part of the panel, on A and B, they really didn't see a whole lot of change in either adenoma detection rate or adenoma per colonoscopy. If anything, it looks like the lines are coming down. Now, they also looked at the endoscopist by tertiles, so the top endoscopist, middle, and lower endoscopist as a baseline for ADR, and all of them were pretty decent. And somehow, it really didn't help anyone, and the top tertile got a little bit worse. So the conclusion is that just buying the technology, implementing it without really thinking about how you're going to use it, without putting extra effort into it, might not be enough to improve the quality of the endoscopies we're performing. There's several possible explanations. The one that I think is probably the most likely is that we feel more secure when we have a computer helping us, and then we probably don't examine as much behind the folds. And obviously, the AI system can only see or detect what we're seeing on the screen. So if you got an AI system installed in your unit or thinking about it, just realize that not every study presented so far is as positive as the initial ones, and you do still have to work pretty hard to find those polyps and have the computer help you find them. Which brings me to this third abstract that I found interesting, where they compared 3 different methods of doing colonoscopy: the conventional one, the one with the AI system, and then the one they added a mucosal exposure device. In this study, they used something called endocuff to help see behind the folds. This is an interim analysis of a randomized controlled trial, so this is not a retrospective study like the last one. It's only the first 300 patients, and if you see here to the left is the group that has both the endocuff and the CAD-E. The green bar is the ADR, and you can see clearly that the combination of a mucosal exposure device plus artificial intelligence really is the way to do good colonoscopy and find a lot of polyps. And as we all know, ADR correlates with interval cancer. So if we want to help our patients, we really need to find those polyps It could be a real good conventional colonoscopy. We don't have AI, and a lot of institutions are not happy spending extra money on endocuff because really they don't see the benefit in a direct way. So we can use our old conventional technique, but we really have to work the folds and find those polyps. If you have extra tools to help you get there, that's the way to go. Now that I've mentioned post-colonoscopy colon cancer, I can tell you about this abstract from Boston when they looked at post-colonoscopy colorectal cancer, divided them into two groups. So the group was within 4 years. So obviously the first 6 months they exclude because these might be people who either had a poor prep or they found something or whatever. So you look at 6 months colonoscopy up to 4 years, then look at 4 years up to 10 years. And they compared those two groups. And they used this flowchart that's been used by several other studies now. Very briefly, basically, was it more than 4 years? If so, they consider this to be a new colon cancer. There might have been a small polyp that was missed, but nothing major, because it's been 4 years. Less than 4 years, well, something was missed. Was there an adenoma in the same segment? If yes, was it resected? If yes, then we're going to assume it wasn't resected completely. If it wasn't resected, patient failed to follow up with an advanced endoscopy or whatever, that's a separate kind of problem. Now, if there's no adenoma in the same segment, was the cecum intubated? Was the prep good? If so, we missed it, or somehow it was missed, right? Limitation of the technology, basically, right? We don't find every polyp. Now, if you didn't get to the end of the colon, the prep wasn't good, patient was supposed to come back, didn't come back, a system failure. And if you look at the percentages in the 4 boxes to the right, really the 2 largest groups are the ones where they got to the cecum, the prep was good, and the patient came down with colon cancer within 4 years. The second largest group was the one where there's some issue reaching the cecum of the prep and patient didn't follow up. And when you compare these 2 groups, the less than 4 years and more than 4 years, the 2 visible differences that you can see, the first one is that in the proximal colon, in the people who had cancer within 4 years after colonoscopy, they tended to have more often a polyp in the same location. And so for those who like to tackle large advanced adenomas on the right side, don't forget to do your short-term surveillance, make sure you're resected completely. If in doubt, send them to someone else, that kind of things. On the right side of the slide, you can see the stage, and the scary thing is that the group that got diagnosed with post-colonoscopy colon cancer within 4 years, well, that top blue color part of the bar graph, that's stage 4 cancer. So in fact, they did worse. So in conclusion, what the authors concluded is that 90% of post-colonoscopy colon cancer within 4 years after colonoscopy are potentially avoidable if we have a better colonoscopy quality, lesion detection, what have you, especially that within 4 years tend to have a more unfavorable clinical profile, higher stage. Many of them tend to have a large index polyp at the same site. My own take on this is something we've been talking about for years now. So if the prep is not that good or didn't reach the cecum, let's not say this is like sigmoidoscopy, come back in 5 instead of 10. Let's try to repeat it and get it done. Because if they have interval cancer, it tends to be bad. I was about to talk about a study called the Clipper study, talking about clips after EMR, but as Dr. Rex has some slides about it, and I'm really looking forward to hear from him more details about how to clip and how to get good clips, I'm going to skip immediately and go to this one, where this is a group from the University of Chicago that looked into polyps, large polyps that have been previously manipulated. So retrospective study, polyps all more than 10 millimeter that have been manipulated, meaning either biopsied, partially snared, or were tattooed with a tattoo extending under the polyp, which we really tried to avoid. And they compared those who had the EMR, the definitive treatment done more than 6 weeks after the index colonoscopy versus within the first 6 weeks. And they had about 250 polyps. The majority have been biopsied, although a few had partial resection. And they noted fibrosis during the EMR in about a quarter of the cases. The fibrosis was a lot more often in those who've been previously manipulated. And when they did the multivariate analysis, they found that resection within 6 weeks decreased risk fibrosis almost by half. Now, the problem is that those that had fibrosis had a lower en bloc resection, much longer procedure time. They had to resect the polyp many more pieces. They didn't see a difference in recurrence rate, but that's probably a matter of study power. So basically, in conclusion, if you see a large polyp that you're planning to either bring back on a day when you have time to deal with it, or refer them to someone else, and that kind of things. And unless the polyp has clear malignant features, we should probably not mess with it. We shouldn't biopsy it. Even a biopsy could affect the quality and the efficacy of the resection. Definitely don't try to snare it if you're in the middle of a busy day and it's a really large lesion and get a big sample or a big biopsy with a snare. But if any of this happens, they're going to refer them somewhere else or going to reschedule them, make it happen within the first 6 weeks. Because the longer you wait, the more fibrosis, and then the worse the patient's outcome. After colonoscopy, when do we bring them back? This study from Mass General looked at bringing them back in 6 months, which is what we traditionally do, versus 12 months. And their hypothesis is that maybe we're overdoing it. So they looked at patients who were supposed to come back kind of during the pandemic era that got pushed out. And they compared the 6 months to 12 months. Now, they had to do a propensity score matching to adjust for different confounding factors. And the endpoint was recurrence rate. And they had about 137 patients. Half of them were recommended to come back in 6 months, half of them at 12 months. And the biopsy-proven recurrence was about 6%. Really not very different. The factors that made the physician be okay with 12 months follow-up were the lesion size. So the larger lesions were told to come back earlier. High-risk histology were told to come back earlier. And number of resected pieces were told to come back earlier, which makes sense because all of these are predictors of recurrence. Now, when they adjusted for all this, they still didn't find the difference. So in conclusion, they found that, first of all, many endoscopies do deviate from the 6 months. And the recurrence rate in this non-randomized kind of practice was about the same. And so the conclusion is that we could potentially individualize. So not every EMR is definitely at 6 months. Maybe if you resect it in 2 pieces, you get really good margins, the polyp wasn't that bad, and the histology is not that terrible. You could possibly push it out to 12 months without having any increased risk of recurrence. But definitely this is not for every single lesion out there. And the last abstract I'm going to present to you before I turn it back over to Dr. Rex and some more abstract is this about ESD. So I personally don't perform ESD, although I see several of our colleagues in the room here who have been, in the last few years, getting more and more proficient at it. And every now and then, we have to refer a patient for ESD. So the question is, are we really doing the patient a, how to say, like affecting them in a negative way by attempting an EMR and then failing, then send for ESD? Should we have sent those patients for ESD right away? So in this study, which is a prospective registry, mainly from North America, when they looked at patients who've had previously attempted colorectal lesions, so they created a new acronym here, so EMRs, resections, whatever, and failed, and then were sent for ESD, and they looked at the success rate, en-bloc resection, R0 resection, adverse events. So they had 360 previously attempted lesions, mean size was 40 millimeter, 2/3 had an EMR, and their success rate was pretty good. So the en-bloc resection rate is about 90%, R0 resection about 80%, curative resection about 80%. Mean procedure time is over an hour and a half. So obviously this is not a quick and easy procedure. Adverse events happen in about 11% of patients. Half of them happen intra-procedurally, and most of them were fixed right away endoscopically, including perforations and bleeding. Most patients were outpatients, in fact. Very few were even admitted for observation after these 2-hour-long procedures. The other 5% of patients who had an adverse event post-procedure, the majority were bleeding. Only 1% of patients out of this whole cohort required surgery, 1 for perforation, 3 for other adverse events. And the recurrence rate was 5%, which is a little bit less than what I just showed you in this EMR study. Obviously, this is patients who failed an EMR, went for ESD. But the conclusion, in my opinion, is that a salvage ESD is still very effective with a high rate of en-bloc and R0 resection when performed by experts, which makes me feel better about attempting EMR for all large polyps. And if for some reason, I can't do it and I send them to someone, hopefully within 6 weeks, they can still salvage the situation and cure the patients of this precancerous lesion. So that's all I'm going to present to you today. Save questions for the Q&A at the end of the session today. Thank you.
Yeah, so that was really great stuff, Fadi. I want to make a couple of comments and see your reaction. So I want to remind people that our guidelines actually say that if you piecemeal something less than 20 millimeters, you don't have to bring it back in less than 3 years, right? Everybody remembers that. Piecemealing and coming back at 6 months is for lesions that are under that are 20 millimeters or larger. Is that fair? Because I see people in the community a lot of times, they'll piecemeal something that's 14 millimeters and they think they have to bring it back in 6 months or a year. And it's not true.
I completely agree. Oh, well, I can speak loud enough.
Oh, there you
well,
go.
I completely agree. And I have to say, like, is it 20? Is it 15, right? I mean, something that's slightly less than 20. And I'm sure we've all done it. But yes, we have to always remind ourselves, if you take, in fact, it's worse, if you have like an 8 millimeter polyp, you cut out, see a little piece left, that's not a piecemeal EMR. This is just a polypectomy, right?
Yeah.
Like, they could go all the way up to 7-10 years if you really cut it out.
Right.
But yes, I agree
Now,
with you.
the other part is about the ESD study. So do you feel that we need ESD on every polyp that's been previously partially resected? Is that the conclusion of that last study? Because there's no randomized controlled trial. And I get tons of polyps referred to me that we remove by just conventional methods. They've got scarring along one edge. We take them out by EMR. We avulse the stuff that's on the scar, and we don't perforate any of them. And it takes way less than an hour and a half on average. So it seems like until we have a randomized controlled trial, that's great from the ESD enthusiast. But when you ask an ESD enthusiast how he's going to manage something, it's like going to an Italian restaurant and wondering what kind of food you're going to get, right? They say ESD to everything. So I look for reasons to not do ESD just because it's so time consuming.
So this study was all about people who were referred after a failed EMR, presumably, although they don't say that in the abstract, by experts. Now, yes, I completely agree with you. Like if someone had an EMR, which was like a partial resection, then we go back to a previous study about reattempting it within 6 weeks and taking care of business. But I mean, I've had patients that some of my colleagues in the room have received from me where someone has had literally EMRs, transanal resections that recurred, and you just don't get any lift, and the lesion's huge, and there's just nothing you can do. And you're talking about ESD versus like an APR.
Well, I mean, even then, I'm just saying there may be other methods. But the ESD in that situation is a nightmare too, right? It's a lot of fibrosis. So, we'll come back to all these things. Is there any time left? Yes. Okay. So I'm going to show this one study that was presented at DDW. It's called the Clipper study. So it's from 19 Dutch hospitals. These were all lesions in the proximal colon and greater than 20 millimeters in size. So they are selected for delayed bleeding, right? If you want to do a delayed bleeding study, you have to get a lot of bleeding in your control group. And the way to do that is to pick large lesions in the proximal colon that you remove by electrocautery. So it's a good group of patients. They got complete closure of the defect with clips in 71%. And they had delayed bleeding in 9% with clipping and 6.1% without clipping. No difference, but sort of looks like there's a trend toward clips cause bleeding. So they used the Olympic Quick Clip Pro, Olympus Quick Clip Pro clip, and so the conclusion was it was not effective. So this was like a surprise because this is the right group of patients. I talked to the chief author, Peter Searsma, who's the editor-in-chief of the journal Endoscopy, the main ESGE journal. And he said that these were not necessarily expert endoscopists. They were people that did referral, but he thought this was more of a community-based clipping situation. So if you look back through the literature that supports clipping, the top study there is our original uncontrolled historical controls, not randomized study. And then the U.S. POLE is the U.S. Randomized study. Albinez is the Spanish randomized study. And then Gupta is Michael Burke's multinational study. And these all suggest that clipping is effective, and it's effective specifically for lesions 20 millimeters in size that are proximal to the splenic flexure that you removed with electrocautery. And I want to mention that because it's, again, something that I see. I saw somebody do it. I saw somebody demonstrate it, not demonstrate it, but show a video of it at a big course, do a very nice cold EMR on a lesion in the proximal colon, and then closed it with 5 clips. I mean, it wasn't bleeding, but the whole beauty of cold resection is that you don't need to clip it, right? It's more cost effective. So unless something's like just keeps bleeding when you resect it cold. You know, that's when you don't use clips. Even if you're nervous, force yourself to not use clips. So the criteria for clipping are 20 millimeters or larger, proximal to the splenic flexure, and you removed it with electrocautery. So it raised the question, if you could start that video, because I said to Peter, I said, did you make videos, you know, of all these clip closures so that we can evaluate them as to whether or not the clipping was done well? And I don't know that we hear enough about it, but I just want to mention a few things about, I guess, my own sense about what effective clipping is. So in general, when you're clipping EMR sites, you want to make sure, the first thing is make sure that the tissue is buried in the clip. If you're placing clips and you can see any part of the arms that doesn't have tissue all the way up to the stem of the clip, that clip was suboptimally placed. So a lot of times you need to manipulate the tissue to do it. And probably the most common maneuver that I make is to orient the clip in the up-down direction and use the bottom prong of the clip to force the tissue down so that the defect is en face to you, so that it starts to fall into the clip orifice. And that's the key thing. You want to push a little bit on the clips. These are Boston clips. You can only push on them so hard because the prongs will start to bend if you push too hard. I do think if you're going to go for it, you might as well really go for it. And I tend, like I said, there's a little defect there. I'm going to put another clip in there. You can oftentimes manipulate the clips. We have this little cap on the end of the scope, which I use for EMR. Fadi was mentioning the EndoCuff Vision, which is the device that I like to use for routine screening and surveillance. But when I'm doing EMRs, I usually put this little distal attachment on there, and it helps you manipulate clips, one of its many uses. So we're literally pushing clips down that we've already placed, and that's forcing the defect at us. But the idea is force the defect at you, make sure you get the clips all the way up into the defects so that they're really buried, so that they're going to stay on there. If you look at the U.S. consortium study where bleeding was reduced, but when the bleeds occurred, they occurred on an average at 8 days after the procedure. Whereas the people who were not clipped, they bled an average of 24 hours after the procedure. So I interpret that as people bleed if you clip when the clips fall off. Right? So the whole idea is place the clips securely. Next slide, please. Oh, I can do that. Okay. So let's see. If you start that video, please. So these are Cook clips, which are bigger and stiffer, and same kind of thing. Most of the time, you want to be even if the defect is it's greater in the longitudinal direction than it is in the transverse direction, so it's tempting to turn the clips upside down. Most of the time, the clips will bury better if you orient them in the longitudinal direction, down the lumen of the scope. So we put them in the up, and if you're to the right, you can clip either down or to the right. Almost impossible to clip to the left or up and clip accurately and clip with force. So these are bigger clips. I like these because you can push on them harder without bending them. So we're putting the clip down. Now sometimes the defect is too big to clip, right? And there is nothing wrong with putting a couple of clips right in the middle of the defect, not touching any mucosa, and pull the edges closer together. And then you can clip around those clips. I'm going to skip this, but here is this, if you could start that video. This is this new clip, the Mantis clip. So one way to use this, if you're really en face, is you can pick up one wall with the clip, and it's got these hooks on it. So when you reopen, it tends to hold on to the tissue. You know, so, and you can see there's a clip right above that is right in the middle of the defect, sort of closing that defect. So these clips are brand new. I don't know if how they're, next slide, let's go again. Video on, please. So these are being promoted as a closure clip. Could you start that video, please? And again, they've got these hooks on them. So using that orientation I was mentioning, where you're sort of up and down, what I found is the best way to use them is to take that prong of the clip, put it in the mucosa on the anal side of the lesion, kind of hook it in, dig it in, and then just drive the scope forward, go across the defect, grab the mucosa on the other side, and pull the two together. So here we are again. We're going to try to go over a big area. We grab this bottom part of the mucosa, lift it, and just keep going with the scope now till we get to the other side, and then pull the whole thing together. Then once you've got the edges together, if you want to bring some more tissue. Now, with regular clips, I would tend to not do this thing of stretching the mucosa because I always felt like the tissue would tear. But it doesn't seem to, at least in the short term, with these clips. But nobody's got a huge amount of follow-up yet to see how long are they staying on longer, or are they otherwise different. So that's an option. And okay, so I'm going to stop there and run through this because I'm seeing red showing everywhere. And could I go back one? Am I over by 5 minutes? Is that what that means? Yeah. So let me just talk about one or two abstracts, and then we'll have. Do we have time for questions then? Okay. So this is a quality study from the VA showing that the surgeons don't do as well with regard to detection as the gastroenterologists do. And I'm telling you, we have seen this over and over and over again. The surgeons have lower adenoma detection rates on average. They don't prevent as well against cancer. And that, we're not going to stop anybody who's doing colonoscopy from doing colonoscopy. But I think the point is, from a patient care standpoint, that you should feel absolutely justified in demanding that everybody in your system participate in your quality program and make measurements. Nobody gets off the hook because they're not a gastroenterologist. Appropriateness of screening surveillance recommendations. I'll just show this one, and then I'm going to stop. This one has been, a couple of these studies that Fadi showed have been fully published, and this one also. But this is a look at whether or not people are following the new screening and surveillance recommendations, specifically the polyp surveillance recommendations. So we've got new surveillance recommendations. And I will say that we still have the most conservative surveillance recommendations in the world. So a huge portion of the world is when they find patients with what we consider low-risk polyps, 1 or 2 tubular adenomas under a centimeter, they stop surveillance. They say you get no surveillance. You go back in the screening pool. So 10 years from now, you can have a fecal immunochemical test or something, but they don't keep doing surveillance. So our surveillance recommendations, even with the updates, they're the most aggressive surveillance recommendations in the world. And what this study shows is that people still are recommending intervals that are shorter than what is in surveillance. And I just think it's a reminder that if you have a high adenoma detection rate and you're getting good bowel preps, you have to feel confident in your findings and use the surveillance recommendations. And I'm going to stop there so we have a few minutes for questions. Thank you.
So we'll spend the next 10 minutes or so on questions. If anyone wants to come up to the microphones and have a couple questions. If not, I got a whole list of questions, but I'll wait to let them ask.
Dr. Rex, could I ask you, one of the populations I find the most challenging for colonoscopy are the chronic spinal cord injury folks. Do you have any tips for those patients? No, I don't, and I can't say that I've done a huge number of them. I know it's a challenge to get them prepped. A lot of them have, a kind of a dilated, elongated colon. So I typically will give them, extra prep. I like meet them beforehand, make sure that we've started the prep very early, that their bowel regimen, that we're sort of way ahead of it, repeating it more often than they usually do, and then I would go in, if it's dilated, I do the same technique probably that using for a redundant colon, which is basically, when you have a dilated colon, that will soak up the length of your insertion tube in the same way that a really long colon would, because each each turn that you go around, you use more of the scope and when the colon's dilated. So keep it collapsed underwater. But you know, it's very hard to go in underwater when the prep is bad, right? So you got to start off with a good prep.
Hi, Dr. Rex. How are you? Good to see you again.
Hi, Mustafa. How are you?
Yeah, good. Thank you. I left IU many years ago, and I still have one question that I forgot to ask you when I was your fellow at IU. And that is, over the years, I developed a technique of the short scope colonoscopies. And so I tend to reduce all the loops, and even if I'm able to get in, I try to reduce. And by the time I get to the cecum, there's no loops. I only have 50 maybe centimeter of the scope inside the patient. But the problem is that by the time I get to the proximal, maybe mid-ascending colon, I just cannot get to the cecum and intubate the cecum easily. I have very short scope, and I could get to this, that point in maybe 3-4 minutes, but then I end up spending a lot more time just to try to intubate the scope. I try to do some transverse colon pressure, kind of suction myself into the cecum, and often I'm able to intubate, see the cecum, but if there's any work in the cecum, I still cannot do it. Is there any special next step technique that can help me save more time and kind of get to the intubated cecum and see if there's any polyps I can remove easily?
Well, so you can't be hesitant to put enough scope in to get done what you have to do. And there's a reason why we have 168 centimeters of insertion tube, because a lot of times we need to use it. And so I'm very willing to put loops in and to get enough scope in that I can get right down on top of the cecum or a lesion that I found, either so that I can inspect an area or so that I can see it. And if that means putting a lot of scope in, I'm quite willing to do it. At the same time, what you've described is good technique. I think when you come around the hepatic flexure, it's a great time. You're often looking down the lumen of the right colon, and that's a good time to rather than push the scope forward, to rock it back and forth. That rocking motion helps the colon to slip back over the scope and deflate, right? So you're deflating so that the cecum starts to come up at you, and then you need to push less scope in. But if that doesn't work, I'm going to use pressure and push on that scope till I get down there and see everything, right? We have to be able to get there.
Pressured area that I can anticipate where the loop is going to be induced, and I can kind of cover it in that case?
Yeah, so I mean, in general, so I would try right flank is often helpful in that place. Sometimes lifting up on the cecum, but sometimes you got to go back because loops are generally in the sigmoid or the transverse, right? So it's either going to be pushing on the sigmoid or pushing up in the lower abdomen on the transverse. If you look at CT colonography studies, the CT, the sigmoid and the transverse are the two longest sections, and on average they have 5 flexures in them. So you got to remember that in some patients, when you're not going down there, if that loop is transverse, it's going down. It'll go down close to the pelvis, right? So straighten it and then try to push up so you can hold it up higher, and that may help.
Thank you. It's good to see you again.
Thank you. So, likewise, Mustafa.
Dr. Rex, I'm going to mention something real quick, and I love it that you talked about it, but just for the sake of any fellows in the audience, I think I want to expand on it. So we teach our fellows to avoid loops, and they end up, the minute they feel that scope's not going 1-to-1, reduce right away. And you could try that once or twice, but after that, you frequently have to make the loop before you can reduce the loop. And sometimes they get to that mindset, well, I don't want to have a loop. And so they push in, they pull back, they push in, they pull back, and they're not making any motion. And you do have to get to the next loop frequently, or not, sometimes, before you can reduce. Now, obviously,
you're saying we scare them too much about making loops. Yeah, exactly.
And then there's that situation that's kind of similar to ERCP, that somehow in ERCP they call it the long position, when the scope is looped all into the stomach. It's not the best position, but sometimes that's what you have to do. So sometimes you have a polyp in the proximal colon, and you have to work with the loop. Yeah. Now, obviously, in the middle of polypectomy, things start sliding, and then the tip is a little bit more proximal, and you have to readjust everything. But there are times where you're not in the best position, and it is what it is.
Yeah, and it's always, I always say when we're going in and taking out large polyps, and I say to the fellow, one of the most important things that's going to happen here is you try to keep the scope straight, because you just have better torquing ability and better ability to position the lesion when the scope is straighter. But you're right,
Exactly.
if you got to do whatever is required.
Yeah.
Hi. Good morning. Thank you so much for your talks. My name is Grace Kim, one of the fellows from University of Chicago. I had a question for Dr. Rex. You mentioned that when you have a big polypectomy site, you sometimes clip the middle of the polypectomy site so that you can approximate the lumen. Since you already thinned out that mucosa, are you worried about perforation when you're clipping it all?
No, not as long as it's a good question because people worry about it. So you're not actually clipping the mucosa at that point. You're putting the clips directly into the submucosa. And there's absolutely nothing wrong with that. You still got the muscularis propria intact, below you. And so that's fine. You're putting the clip there to pull the edges together. But you would do the same thing if you had a really large defect and you had a perforation from EMR. EMR perforations are typically, very small. They're just a few millimeters in size. And you've got to close it by putting the clips directly into the submucosa, right? And so, yeah, don't worry about that. Now, there were older clips that had more like a needle point on them, and I wouldn't use those for it. But all the clips now have a blunt, sort of rectangular shape to the tip. The other thing is I don't fully know about the mantis clip. People are using the mantis clip right now to put mucosa to mucosa, and whether those prongs on there are okay to put into the submucosa, I'm not sure. I've been a little hesitant about that clip, so I'm glad you asked that question. Yeah, hi.
Hi, Roberto Gamara. I have more of a perspective, and I would love to hear some feedback from the panel. I wouldn't, as somebody who performs EMRs and ESDs in the community, I wouldn't want for people to walk away from this conference to feel like, doing an EMR to attempt a resection is always okay because my ESD colleagues can go ahead and take it out. I look at ESD as an organ preserving technique, and it's a tool in the toolbox. And so the question of when to do EMR versus when to do ESD really has to do with whether or not you think that there's malignancy and the need to obtain accurate margins, to know whether or not there's accurate margins there. And so if for somebody who doesn't perform ESDs, becoming very adept and knowledgeable about predicting whether or not a lesion has malignancy by understanding the Kudo classification or the NICE classification, I think is critical in deciding when to apply an EMR versus referring out to ESD.
Okay, big discussion, and I'm glad you brought it up because it's very fair. So the discussion we were having earlier related to lesions that have been partly removed by EMR that endoscopically appear benign. From my standpoint, there are multiple ways to skin the cat on that, and ESD is not the only solution to fibrosis. But what you're saying is that the rationale for ESD is that we want, when we have cancer, to have an en-bloc resection because we believe it gives us a better pathologic assessment of those patients who may not require surgery. And I think that's fair. That whole discussion, I prefer myself to put in the context of when do you need en-bloc resection versus piecemeal resection. Because there's a fair number of lesions that you can remove en bloc by methods other than ESD. We have the full thickness resection device. We have underwater resection for things up to 25 or 30 millimeters. And then there's the whole issue about the rectum versus the rest of the colon. So when we get somebody who has superficial, invasion, and we have that clearly documented by ESD, then we can potentially save them, an operation. So the question becomes, is that always critical? Is that the most important thing in the world? I think in the United States, the biggest problem we have with overuse of surgery is people being sent to surgery for benign colon polyps, right? And so there's a question if you're really swamped and you've got a whole bunch of lesions being referred to you, do you want to spend hours and hours doing ESD when you could be trying to do EMR on lesions and prevent benign lesions from going to surgery? So my cutoff is the rectum versus the colon. I don't care so much if every once in a while, I've got to send somebody to surgery for a segmental resection in the colon, as opposed to the rectum, where the consequences are greater. So I think that things in the rectum that have nodules in them that aren't just homogeneous granular lesions, those in my practice are the best candidates for EMR. But I think your point is very important, that we all need to be able to make an assessment of when there's a risk of cancer and when we want to try to get an en-bloc resection. I'm willing if there's a granular lesion in the right colon, I would be willing, rather than do ESD, to cut the whole benign part of it out by EMR and take the little lousy part out with the full thickness resection device. It's faster, and it's hard to argue that the path specimen can be any better than with full thickness resection. But this is a really, really important point and question. Thank you for bringing it up. Comments?
I think they're amazing questions. The responses were incredible. Both your expertise and presentations were amazing, so thank you guys very much. I think it's time to go to the next section, and then any questions we can do afterwards in the halls and everything. So Dr. El-Sheikh.
Thank you so much for those excellent talks and the wonderful discussion that followed. It was extremely pertinent to all of us, especially me, even though I'm just a simple motility provider. So welcome to our esophagus and stomach portion of the course. I have the pleasure of introducing Dr. Dustin Carlson and Dr. Rick Saad, who are joining us from Chicago and Maine. Dr. Dustin Carlson is Assistant Professor of Medicine at Northwestern University Feinberg School of Medicine, where he serves as the Director of the Esophageal Center at Northwestern, as well as the Functional Lab. He also stands on the International High Resolution Manometry Working Group and is also the chair of the American FLIP Working Group as well. His research and clinical interests are in all things esophagus, benign esophagus especially, including achalasia, reflux, and EOE. And today he'll be giving our state-of-the-art lecture on GERD. Dr. Rick Saad is a gastroenterologist at Maine Medical Center. Yep, you can come on up. Where he has been since 2021. Before that, he was local at the University of Michigan for 16 years, and prior to that, he was in the United States Army Medical Corps for 7 years as an internist. Dr. Saad is very involved in both the ACP and ACG, where he's involved in the Board of Governors. Both of them are prolific authors, Dr. Saad particularly in disorders of brain-gut interactions, and he'll be giving us our DDW updates today. So without further ado, Dr. Carlson.
Well, thank you so much for that kind introduction, and thank you so much to the organizers for inviting me and allowing me to participate in this great meeting, and really congrats to them. Fabulous meeting. I'm really appreciative of being here. So I get to talk about the state of the art of GERD. And so certainly we all recognize GERD, incredibly common. Based on some recent data, more than 4.5 million office visits a year, healthcare expenditures over $12 billion, and that includes all of esophageal disease, but the vast majority of that is for GERD. And especially with GERD becoming a really problematic issue when there's a lot of refractory symptoms, and some studies are suggesting that 30 to 50% of patients are actually unsatisfied with symptom control on their present management regimens. Obviously, patients get endoscopy, and some will have long segment Barrett's and erosive esophagitis, but the vast majority of those patients with GERD actually will be endoscopy negative. And so really what I'm going to focus on today is kind of a few key issues that I think come up in our current state of the art for GERD. One regarding to the management approach, and certainly that comes down to whether or not to start with an empiric treatment trial or versus objective GERD diagnosis, kind of the who, what, when, and how to test these patients, and really to help triage patients and tailor treatment. When it comes to treatment, looking at kind of acid suppressive therapy, but also I'll touch on anti-reflux surgery as well. And so a couple key concepts that kind of come into all of this and really help frame the challenge that we sometimes see with these reflux patients. One is that there's this spectrum of these reflux disease states, or reflux disease syndromes, if you will. And I borrow this from the recent, or at least the most recent, Rome document, looking at this spectrum here relative to acid exposure, but also esophageal hypersensitivity. And when we see patients with erosive esophagitis or non-erosive reflux disease, the symptomatic presentation can be exactly the same as those patients who come in with functional heartburn, whereas obviously the underlying pathology here is dramatically different. Another important concept is how patients respond to treatment. And there's a lot of things that get labeled as GERD, a lot of different syndromes, a lot of different symptoms that get tossed in there. And the management really does have major impacts with how their patients are presenting. Certainly with PPIs in particular, very effective at healing esophagitis, both mild and severe esophagitis. And this great slide that I borrow from one of my colleagues and mentors, Peter Karillis, showing these gain over placebo here. And we see this with PPI gain over esophagitis healing. But even in patients with non-erosive reflux disease, the symptom matters. Heartburn relief having a much better response to PPIs than some other things like regurgitation. Chest pain responsive when there's documentation of objective reflux. And then you get into other things that are the extraesophageal reflux symptoms, the hoarseness, chronic cough, asthma, all these things fall into the same bucket, but really very little gain when you look at these on a large-scale population level with improvement in PPI compared to placebo. And so how do we put this together? And so I think one of the key factors is really when do we do empiric PPI trials, when do we continue even empiric PPI trials, and when do we use ambulatory reflux monitoring? And so kind of some of those questions that come out of here are, really why do we use ambulatory reflux monitoring? And certainly, as I hope I've already displayed, is that there is a need to actually objectively diagnose GERD, especially when endoscopy is not in and of itself diagnostic. This can help us actually assess the lack of response to therapy, particularly when people are not initially responsive to PPI, and in particular when the stakes are a little bit higher and we're thinking about anti-reflux surgeries or anti-reflux endoscopic procedures at this point. We really want to have a firm diagnosis before subjecting patients to those sometimes irreversible therapies. And so with ambulatory reflux monitoring, we can answer a couple of key questions. The prime one is there GERD present? Is there an abnormal degree of esophageal reflux burden? And further, it actually can help us define whether or not reflux and symptoms are truly correlated. And so even here, kind of coming back to this idea of the spectrum here, we can look at endoscopy alone as an upfront test. All this is going to do is really show us whether or not there's erosive esophagitis, if there's long segment Barrett's esophagus, and diagnose reflux on an objective marker. But beyond that, we really do rely on ambulatory reflux monitoring to otherwise classify patients into these reflux disease states, with non-erosive reflux disease having pathologic acid exposure, whereas with functional heartburn, these patients are going to have physiologic degrees of acid exposure. All right, and so kind of coming back now to some of the recent best practice guidelines from the AGA, in this clinical practice update, still recommending using an empiric trial for patients who are presenting with the typical reflux symptoms, so patients with heartburn, regurgitation, and to start with an FDA-approved dose of PPI therapy, and to try this for 4 to 8 weeks, considering an escalation to BID dosing if there's not an initial response to treatment. Beyond that, if there's not symptomatic relief, this is something that ambulatory reflux monitoring may be needed. So here, kind of thinking about this response to empiric PPI trials, and looking at this meta-analysis from a number of years ago at this point, but response to PPI in and of itself is not going to confirm or even exclude GERD as the diagnosis. And a number of studies here, whether or not they use erosive esophagitis or use ambulatory reflux monitoring, are showing a sensitivity of a PPI trial in the 70% range, with specificities being much lower, and almost being a coin flip at this point as to whether or not someone may have GERD depending on a PPI trial. And so this is where this AGA clinic practice update is suggesting that certainly we're using ambulatory reflux monitoring if patients are not responsive to PPI. At this point, really want to confirm whether or not GERD is present to help us facilitate future treatment. But even in patients who do have a symptomatic response to PPI, that this PPI appears to be a chronic component of therapy, that after a year, ambulatory reflux monitoring should at least be offered to patients to help confirm that diagnosis, and really help support the use of PPI in the long term. I think, and this is something that I've certainly implemented into my practice, and especially in some of these concerns with PPI safety, which I'll touch on a bit later. This really does help kind of answer some of that question when patients come in and ask, do I need to be on PPI? Do I need to treat my GERD on the long term? All right, but what about with these extraesophageal or atypical symptoms? And I think here, as we mentioned, the response to PPI really is going to be much, much lower and have much less ability to differentiate between GERD or non-GERD etiologies. And so borrowing from another AGA clinical practice update, here's where it really is kind of breaking down patients up front, again, using that symptomatic presentation. Patients who have extraesophageal reflux symptoms and are also having typical GERD symptoms in conjunction, that in those scenarios, starting with an empiric PPI trial may be reasonable, and following the typical reflux symptom algorithm may be reasonable as well. But in patients who don't have the typical reflux symptoms and just have isolated extraesophageal symptoms, that upfront testing is really going to be the higher yield, and there's studies showing the cost effectiveness of this approach in reaching an objective diagnosis for reflux up front to help avoid some of the downstream repeat testing and long-term treatment trials that may not be effective. All right, so we decided to use esophageal pH testing. The kind of question next that comes as to which one to choose. And there's really three options. There's the conventional pH catheter, transnasal catheter with a single pH sensor. And then I think this is a test that really, in my mind, has kind of the least, kind of the less of all performance characteristics, and so something we don't use in our practice. And so instead, we're more often thinking about whether or not we're using a wireless pH sensor or using impedance pH catheter-based testing. And really, when it comes down to it, there's some pros and cons between these different modalities as to how you may want to choose which one to use. Among those factors, patient tolerability is a key one. And this is something that's certainly better with the wireless pH testing. Not having a transnasal catheter, patients generally will prefer and can perform kind of more adequate lifestyle components. There is a small risk of capsulate pain, of attachment pain, chest pain in some patients, which for some patients is a concern. The duration of monitoring, this is certainly, I think, one of the key advantages with using wireless pH testing. And in our practice, we use 96-hour testing, and really being able to assess for day-to-day variability, in my mind, I think is the biggest advantage of using wireless pH testing over a catheter-based pH test. However, the place of pH testing does require sedated endoscopy, and so catheter-based pH testing and pH impedance does offer the potential to do pH testing without the use of sedation, just placing it transnasally. And pH impedance also offers the potential of adding dual channel capabilities. And I'll come back to that a bit more, but assessing for non-acid reflux, also assessing for proximal extent of reflux. With the idea of being more physiologic or more real life, this is something with reflux. We note that life causes reflux, activity, exercise, diet, all these things that when patients have a transnasal catheter, they dramatically alter in their life, so you may not get the best detection of reflux. And certainly with ease of interpretation, wireless pH testing has an advantage. But in the end, this is one of these things that we often argue about in motility conferences, and it's a fun debate to have, is pH testing versus pH impedance, which is better. But ultimately, a lot of times, I do kind of just talk to a patient and ask, what would you prefer? Do you want to get another endoscopy if they've had one previously and have a capsule placed? Are you worried about attachment pain? When I talk to a patient and they describe, burning chest pain every time they drink some water, that's someone I'm probably not going to clip a wireless pH capsule into. Versus someone who thinks they may prefer or can't tolerate a transnasal catheter. But if patients are completely indifferent, then often here's where I get to apply my approach and consider the clinical scenario. And here it kind of comes down to what that clinical question is. And if you really have a low probability of GERD, or basically your GERD is yet to be proven, in my mind there, I'm still kind of wondering, is GERD even present? And in my hands, in my practice, the extended monitoring of a wireless pH sensor is really the key thing I'm looking for here, and I prefer wireless pH testing, and this is performed off PPI. However, if someone has known GERD, but yet they still are not having a response to therapy, this may be someone that we consider trying to figure out why they're not having a response to therapy, and so determining whether or not there's abnormal acid exposure, abnormal reflux parameters on PPI with pH impedance can be considered. something borrowed from the Lyon consensus is this idea of proven versus unproven GERD. Really, that comes down to this pretest likelihood. And the Lyon consensus listed only LAC and D esophagitis as proven GERD. In my mind, Los Angeles B esophagitis is proven GERD as well. But for the most part, without definitive objective diagnosis of GERD, anything that has anything other than that, I look at that as being unproven GERD and somebody that I would consider doing pH testing off of PPI on. And so finally here, just kind of breaking it down, lending to interpretation of it as well. This algorithm, again, borrowed from the Lyon consensus about patients who are assessed for reflux. But really in those with unproven GERD, these are patients who are going to get pH testing off of PPI. The question there really lends whether or not GERD is even present. And from an interpretation standpoint, using acid exposure times less than 4 as being physiologic, acid exposure time greater than 6 as being pathologic. Of course, that leaves a borderline sense in the middle where you have to look at kind of more factors, reflux episodes, or some other potential metrics to help identify whether or not GERD might be present. And then also in patients who do have proven GERD, and this is some patients who are now doing pH impedance on PPI, there is some recognition that there can be overlap between GERD and functional syndromes. And maybe the reflux is adequately controlled on acid suppressive therapy, but they can have a functional mechanism that's still driving symptoms, even if underlying GERD is present. All right, some data here looking at this. And this is a study that we published a couple of years ago now, really looking at the benefit of wireless pH testing and really using this day-to-day variation, using kind of the full extent of a 96-hour wireless pH protocol to help triage the severity of patients. We looked at this among patients who were PPI non-responders and trying to find patients who we could actually stop PPI on. And when patients had obviously normal wireless pH testing, they were generally able to actually stop their PPI and come off of that effectively. But even seeing some of this step-up severity of reflux when you have a single day positive or even 2 days positive, a little higher likelihood of actually being able to discontinue PPI. So really using this in my practice to help not just diagnose GERD as a dichotomous yes or no, you've got GERD, but to look at this on a spectrum of severities. And patients who do have infrequent GERD, those people with maybe one positive day on a prolonged test, someone who may be more amenable to getting on-demand therapy, who we can actually treat with more lifestyle modifications, whereas those who are really having persistent reflux over the course of the whole study are going to need more chronic, prolonged therapy. All right, some other added value of pH impedance, as I mentioned, there is some ability to detect weak or non-acid reflux, proximal extent, also some ability to detect belching and some of these belching syndromes with pH impedance. Still obviously some ongoing debate as to the utility of weak acid reflux and where that falls from a standpoint between kind of reflux hypersensitivity and reflux, but there are some other components that maybe can be gleaned from pH impedance in these select populations of patients. All right, also often a question comes up about what the role of manometry has in acid reflux, so I at least wanted to address it. And in my mind, the main piece here is really to help evaluate for alternate or contributing conditions. Certainly patients who are having particularly these regurgitation-dominant presentations, achalasia certainly needs to be excluded, and this is of extreme importance prior to considering anti-reflux surgery. But there also are some of these other syndromes, and again, this is the regurgitant-dominant reflux, our patients with predominant belching presentations. So there are some of these behavioral diagnoses that actually can be detected on what we call a postprandial manometry. So actually giving somebody a symptomatic meal challenge and monitoring them, and you can see some manometric patterns that can actually help support some of these behavioral diagnoses. And things like rumination syndrome, supragastric belching are things that will not respond well to PPI or even anti-reflux surgery, but instead will need more cognitive or behavioral therapies. All right, what about medical treatment for reflux? Now we've confirmed reflux, we're going to continue treatment here, and from a medical standpoint, PPIs do remain the mainstay of treatment. And overall, PPIs are safe, though there certainly are some concerns. But there's a new kid on the block with these potassium competitive acid blockers, the PCABs, which yet to be available, but I think are going to be a welcome addition in the not too distant future. All right, PPI safety. I feel like I can't get through a patient visit with at least this coming up, and I spend a lot of time having to oftentimes reassure patients about the safety of PPIs. But a lot of things mentioned: cancer, infections, vitamin malabsorption, bone health, interactions with other drugs, and particularly a lot of concerns with dementia, stroke, and renal disease. However, there's been a number of better, higher quality studies, and this one in particular that was a follow-up study from the COMPASS study, so a randomized controlled trial actually looking at cardiovascular outcomes, but also randomized patients to PPI or not, looking more for GI bleed prevention. But with 3 years of follow-up data in this randomized controlled group, really no risk, increased risk of any of these other side effects or adverse outcomes between patients on or off PPI, with the lone exception of a little signal for enteric infection there. And it wasn't statistically significant, but this is the present is the best data that really helps provide reassurance for the safety of PPIs, though the follow-up here was 3 years. Another key one here, I think, is this great study from Paul Lockhead that actually was a database looking at the Nurses' Health Study, so a prospectively followed cohort really focused on cognitive function and really effectively debunking the idea of dementia, which a lot of patients are very concerned about. And then finally, this nice study here that came from the Canadian osteoporosis group, and really helping show that PPIs did not have a longitudinal effect or impact on bone health. And so these studies, when patients are really looking for reasons why PPIs are safe, I feel like are some of the key ones that I may share with them even and can help support the safeties of PPIs, because in the end, these risks are mostly identified by weak correlations in observational studies, and so don't show cause and effect. High-quality studies support the safety of PPIs much more than they confirm the risks. And then when it comes to the idea of PCABs, for the most part, even though the studies aren't out there yet, I don't think that PCAB is going to be a main use, or at least that PPI safety shouldn't be a main use to prompt our use of these medications. However, with that said, these PCABs are coming, and I think they will be a welcome addition, and not from a safety standpoint, but more from a potency standpoint. And there are some key pharmacodynamic differences between the PCABs and the PPIs. One is this idea of this reversible binding to both active and inactive proton pumps, which allows for an increase in potency, and also an idea of being a prodrug and requiring metabolism for activation. And so this use of timing and taking PPIs compared with PCABs will have another benefit. From a potency standpoint, you can see that one of the PCABs, vonoprazan, more potent from an acid suppressive standpoint than any of the PPIs, recognizing as well that there are difference in potencies across the PPIs as well. And here's really the key seminal study, a randomized controlled trial that was published in Gastro earlier this year, looking at vonoprazan versus lansoprazole for treatment of erosive esophagitis, designed as a non-inferiority study, but actually showing superiority of vonoprazan to both heal, especially severe esophagitis up front, and then also with maintenance of healing of erosive esophagitis. So not yet FDA approved, but maybe become an option in the not too distant future. All right, then finally I'll conclude just to at least touch on anti-reflux surgery, and certainly want to not exclude anti-reflux endoscopy procedures at this point. And here there really are a number of options, and so I don't want to maybe feel like they're left out here. This is not an exhaustive list, but when there's a hiatal hernia, it requires repair. But between fundoplication, magnetic sphincter augmentation, endoscopic transoral incisionless fundoplication, which also now can be combined with a laparoscopic approach to fix hiatal hernia repair, or even gastric bypass. There's a lot of options here for appropriate patients being the key factor. And a key study here was really that published in the New England Journal a few years ago now, led by Stu Speckler, where they looked at patients who had true PPI refractory heartburn. And they all confirmed in all these patients pH impedance testing on PPI and showing abnormal acid exposure in this group, and then randomizing patients to Nissen fundoplication versus escalated medical therapy, so BID PPI plus baclofen plus dicipramine, a tricyclic antidepressant, versus just BID PPI. And in that study, showing superiority of the surgical approach, the laparoscopic Nissen fundoplication, compared to the active medical treatment or control medical treatment. And noting here as well that even this kind of active, this really step-up medical treatment didn't have major benefit over just the control medical treatment. But even in this group, so certainly surgery can be effective and is an effective option for patients. But I think the really key takeaway here was their selection criteria. And in this study, they actually under-enrolled and they didn't meet their enrollment goals. And as part of this VA-based study, they enrolled 366 patients and excluded 288 of them. So really a very, very select group. And I think the key here then becomes that surgery is a great option for these carefully selected patients. The other thing that I think often comes up that we'll kind of leave on is this ongoing question that really still has yet to be answered, but about how the surgical modality may be tailored or if it can be personalized to actually help improve outcomes. And a number of things need to be considered here. One, again, is this primary symptom, this presenting complaint. And in my mind, this is often whether or not patients are really good candidates for surgery. In particular, when it comes to these extraesophageal reflux symptoms, this is a group that I'm very reluctant and really want to have really severe objective testing to help guide whether or not patients are going to be decent candidates there, because the outcomes, at least from a symptom resolution of extraesophageal symptoms, is certainly not as good with these extraesophageal symptoms than it is with typical symptoms. Hiatal hernia, if present, definitely needs to be addressed. And so thinking about a purely endoscopic approach is not going to address hiatal hernia. Combining this with a laparoscopic hiatal hernia repair can be an option for some patients. Weight, obesity, certainly something that needs to be considered as well. And patients with really bothersome objective reflux. Bariatric surgery, particularly gastric bypass, may be the better anti-reflux surgical option for these patients. And then finally, something that often does come up is this idea of esophageal motility and using that to actually triage patients to a particular form of therapy. However, studies in that realm have actually not been overly informative and typically showing that tailoring, especially between a Nissen or a partial fundoplication, is not generally guided by manometry. However, manometry does continue to play a very, very important role actually in excluding some of those other alternative diagnoses, and again, achalasia in particular. But so with that, I'll conclude, really hoping to bring across that, that this objective GERD diagnosis using a combination of tools, endoscopy and ambulatory pH monitoring in particular, is really important to help define these GERD disease states. And using that data can really help direct treatment options in a personalized manner. Kind of which pH monitoring modality to use, something to be basing on a pros and cons between the different tests on their performance, but also considering patient preferences and the clinical scenario. I think PPI is effective and safe when used in appropriate manners. The PCABs will often welcome new treatment, and then anti-reflux surgery certainly out there, and it can be a very, very useful and effective option in those carefully selected patients. So with that, I'll stop and thank you all for your attention.
Good morning. I'd like to take this opportunity to thank the organizers for inviting me back this year. I was in Michigan for 19 years. I raised my family here. I consider Michigan still my home, but I now live in Maine. I will say it is a little difficult to leave the coast of Maine in the summer to come here to Traverse City, but Traverse City is equally as beautiful. So this morning I'm going to give you a few of what I consider to be the noteworthy abstracts presented at this year's DDW in the area of the stomach. So I'm going to start with this study looking at vonoprazan and how it was compared to IV PPI therapy for the prevention of peptic ulcer rebleeding following endoscopic hemostasis for high-risk peptic ulcer bleeds. As you've already heard a little bit from Dusty about vonoprazan, it is a potassium-competitive acid blocker. It binds irreversibly to the potassium ions, and it blocks the potassium-hydrogen ATPase enzyme, which leads to acid production. One of its unique features is you don't have to have the acid pumps on for vonoprazan to work. You're probably familiar with the current ACG guidelines in terms of how anti-secretory therapy should be administered after endoscopic therapy for high-risk peptic ulcer bleeds. It should be given in a high dose for a minimum of 3 days' time. It should be either given continuously or intermittently. And then following those 3 days, patients should be maintained on twice daily PPI for a minimum of 14, or essentially for 14 days total. This helps prevent rebleeding. So this study was a multi-center non-inferiority trial. They involved 174 patients that had either a arterial bleed, active arterial bleed, an ooze, a visible vessel, or an adherent clot, basically one of your Forrest 1 or 2 type lesions. And then they were randomized in an open label format to either receive vonaprazan plus vonaprazan twice a day, which they continued for 3 days' time, and then they went on to take it once a day for a total of 28 days, versus the more traditional IV PPI therapy that we're familiar with, which is the 80 milligram IV bolus and then 8 milligrams an hour for those 3 days, and then continued on twice daily omeprazole for 28 days. Their primary outcome was a 30-day rebleed rate, and as you can see here, it occurred higher in the IV pantoprazole group. So basically, this study confirmed the non-inferiority of vonaprazan to a PPI for the primary endpoint of a 30-day rebleed rate. It also performed in a similar fashion at 3 days as well as at 7 days. Both total and post-endoscopy transfusions were lower with vonaprazan compared to the IV PPI. And all-case mortality, bleeding-related mortality, rescue therapy, length of hospital stay, and adverse events were all comparative between the 2 treatment arms. So bottom line here, the conclusion was that vonaprazan was not inferior to PPIs in preventing rebleed within 30 days in those patients receiving endoscopic therapy for high-risk bleeding peptic ulcer. So moving on, this is a study that looked at adding bismuth to high-dose dual therapy for the first-line treatment of Helicobacter pylori eradication. So high-dose dual therapy originally was devised as a salvage therapy. This utilizes a higher dose of amoxicillin. 3 grams of amoxicillin a day. It can be either divided TID or QID. And then it's combined with either single or double dose PPI that's given anywhere from 3 to 4 times a day. As I mentioned, this was initially devised as a salvage therapy, largely because of the rare resistance to amoxicillin and also the realization that the more acid reduction that occurs, the more effective the amoxicillin is. There's also been an increased interest in this dual therapy because it's less complex in terms of a regimen to give patients, and it seems to be better tolerated. Most of the studies on high-dose dual therapy that have been done in Asia, there are a few in the Western countries. Patients generally don't perform as well in the Western countries on this therapy, and it's been thought to be related to the intake of high-acid foods. So the addition of bismuth has in other studies been shown to improve antibiotic efficacy. So this is the background behind this study. So in this study, this was done in Taiwan. It involved a total of 436 patients who were found to be H. pylori positive, and they were divided into 3 treatment arms. They either received rabeprazole or amoxicillin for 14 days. That would be the traditional high-dose dual therapy. They received the traditional high-dose dual therapy with bismuth, or finally they received what is known as bismuth quadruple therapy, adding a metronidazole and using the more traditional dose of amoxicillin. And as you can see here, the intention to treat eradication rate was actually superior with the bismuth plus high-dose dual therapy compared to the high-dose dual therapy alone, and actually had a lower rate of adverse effects to the quadruple therapy and performed slightly better than the quadruple therapy as well. So the efficacy of bismuth plus high-dose dual therapy was superior to high-dose dual therapy alone. The adverse effects, as I mentioned, were greater in the quadruple therapy versus the bismuth plus high-dose therapy. And it was shown that both resistance to metronidazole as well as poor compliance was associated with the reduced eradication rate with the quadruple therapy. So frequent acidic food intake during the high-dose therapy was also associated with its failure. So bismuth may improve these features of high-dose dual therapy. And the conclusion here was that bismuth plus high-dose dual therapy may offer an alternative first-line or salvage therapy for H. pylori eradication. Moving on, buspirone has been used in many practices for the treatment of early satiety as well as postprandial fullness in patients with functional dyspepsia. This has actually been previously shown, and there's a question as to whether this might work in gastroparesis as well. We do know that relaxation of the proximal stomach occurs with eating. It allows for accommodation of the meal. It's been shown to be impaired both in functional dyspepsia as well as gastroparesis. And buspirone, which is a 5-HT1 receptor antagonist, has been shown in healthy individuals to increase gastric accommodation. It's also, as I mentioned, has previously demonstrated improvement in the functional dyspeptic population in Europe. So the aim of this study was to look at a 4-week treatment of buspirone and see if it improves both early satiety and postprandial fullness in patients with symptoms of gastroparesis. This was a multi-center randomized double-blind placebo-controlled trial. 96 patients were enrolled. They were 18 or older. They had moderate to severe early satiety and postprandial fullness, along with other symptoms suggestive of a gastric origin. That could include nausea, fullness, bloating, or epigastric pain for at least 3 months duration. Most of these individuals were female. 50% had delayed gastric emptying, and 39% of them were diabetic. They either received buspirone 10 milligrams 3 times a day or matching placebo. And the primary outcome was a change in the early satiety postprandial fullness subscore on the gastroparesis cardinal symptom index from baseline to that 4-week time. There were a number of secondary outcomes as well, including heartburn, regurgitation, nausea, vomiting, bloating, upper and lower abdominal pain scores, constipation and diarrhea symptoms, and finally GERD symptoms. So what they found in this study was that there was no difference between the buspirone and the placebo in addressing early satiety and postprandial fullness. In fact, the only subscore that did show some improvement over placebo, or actually showed statistically significant improvement over placebo, was those patients that had severe to very severe bloating at baseline compared to those that had none to moderate bloating. So their conclusions, they had 2 conclusions from this study. Number 1, patients with moderate to severe early satiety and postprandial fullness and other symptoms of gastroparesis didn't benefit from buspirone to improve the early satiety and postprandial fullness compared to placebo. There is, however, a suggestion that those with bloating, moderate to severe bloating, may improve with the use of the buspirone. So moving on to my second to last study to present. This is looking at the efficacy of tradipitant in the treatment of idiopathic and diabetic gastroparesis. So tradipitant is a neurokinin-1 receptor antagonist. This is also known as the tachykinin receptor. It binds to substance P, and its activation leads to nausea and vomiting. So this was previously shown in a published phase 2 clinical trial to provide statistically and clinically meaningful improvement in both nausea compared to placebo. So what was looked at and presented in one of 2 posters at DDW was how it performed in a phase 3 trial. This is once again multi-center, randomized, placebo-controlled, involving 201 adults with idiopathic and diabetic gastroparesis. They had to have delayed gastric emptying, moderate to severe nausea, and at least 1 episode of vomiting weekly. What they found with the phase 3 trial is that they did not meet the primary objective of showing improvement in the nausea score. They did see some improvement at 2 weeks based on the patient global improvement, as well as the overall patient benefit scores at both 2 and 12 weeks. And what they commented on is how high the placebo response was. If you look at this study, the placebo response is in the high 50 to 70% range. So here's their second poster they presented at DDW this year. So what they did is they combined the data from their phase 2 trial that had been published with the phase 3 trial that they had just recently performed. This provided a larger patient pool, and they did the assessment at 4 weeks, not at 12 weeks. And what they did show was superiority of the tradipitant compared to placebo in addressing the nausea, and also overall improvement based on both the patient benefit and the global improvement scores. And then finally, I want to wrap it up with this systematic and review and meta-analysis that was presented at DDW, looking at lumen-opposing metal stents in the management of benign gastrointestinal strictures. So this analysis looked at all studies through the inception of these devices through November of last year. They had a number of primary outcomes: technical success, short-term clinical success, which was defined as improvement in symptoms with the LAMs in place, a long-term clinical success, which is how patients did after removal of the LAMs, and then some secondary outcomes as well. This was a total of 16 studies. The majority of them were retrospective, a total of 450 patients, and follow-up was up to 22 months. Most of these lesions that were addressed with LAMs were anastomotic strictures, and the most common site was gastrodejunal. And as you can see here, they found excellent technical success in the high 90% range. Short-term success was also excellent, 90% range. Success fell off after these devices were removed, so the long-term success dropped into the mid-50s, and then about a third of them required some form of reintervention. And the most common adverse effects were, not surprisingly, stent migration as well as pain. So they did conclude that more research is definitely needed to assess the cost of these devices compared to other treatments, establish their long-term durability, their ideal stent indwelling time, and the ideal time to pursue reintervention. So with that.
Well, thanks again. And yeah, so I was asked to look at some of the updates from DDW with on the esophageal side of things. And so yeah, so there were a few kind of abstracts I thought were of interest that I wanted to highlight here today. First off, to kind of talk about EOE. I think one of the key stories in EOE remains dupilumab. So obviously the only FDA-approved medication for EOE at this point. A fully monoclonal antibody that blocks IL-4 and IL-13. And for those of you early risers, probably heard a bit about this already this morning. There were a number of abstract studies at DDW, generally focused on kind of some subgroup analysis of the key pivotal trial with dupilumab. And so I'll talk about this one of interest here, at least that one that I think jumped out at me, was really looking at using dupilumab based on previous topical steroid exposure. But the underlying thought here is kind of, I think one of the things I went into DDW really seeking to gain was kind of where people are putting dupilumab in their treatment algorithm in EOE, and where does this fall presently. And so here's showing dupilumab again. So this study that looked at this kind of subgroup here was a subgroup analysis of the study published in the New England Journal. And looked at the FDA-approved dosing, so of the 300 milligram weekly, and then looked at the outcome data relative to histologic response as well as endoscopic response in these patients. And so really showing here that when they broke these people down, whether or not they had been on any previous topical steroid, or if they had had a prior inadequate response, intolerance, or contraindication to swallow topical steroid use, it really didn't matter. And here, just looking at the histologic outcome, one thing with this study design is that there was a kind of this run in Part B where patients were randomized to placebo versus dupilumab, and then the dashed line I put in here indicates when dupilumab was started. And so at least looking at the percentage of patients who reached a histologic response, really pretty similar and dramatically improved with the start of dupilumab, whether or not, with really no indication based on topical steroid status. Sorry for the busy table here, but generally if you looked at symptom score, endoscopic EREF score, histologic subscores, similar data in that there was an improvement with dupilumab, and this improvement was actually maintained even at the long-term follow-up outcome. And so kind of the question that I went in wondering was really, where does dupilumab fall here with regard to treatment algorithm? And a number of the clinical symposiums address this topic, and this is actually a table that I borrowed from a review in the Red Journal. But for the most part, people are placing dupilumab actually kind of side by side with elimination diet or topical steroid, and really at least including this in that initial discussion with patients as being a treatment option for patients with EoE who have not responded to PPI. And I think in my practice, this is still something where I'm trying to feel out where dupilumab falls. And I think most of my patients are still at least starting with an elimination diet or swallowed steroids. But with more and more kind of experience in this and seeing really great outcomes, this may fall in here, just kind of a balance of costs and accessibility at this point. But at least when we look at this study from DDW and looking at this subgroup, does topical steroid exposure or response matter? It really doesn't. And dupilumab does seem to be effective in all of those patients. All right, moving on, kind of more to the motility front. There was a study that I found interesting that was actually from the Leuven, Belgium group, looking at this kind of somewhat newer and maybe rare disease, but something called retrograde cricopharyngeal dysfunction. And this is something that I feel like we're seeing more and more of, and there's almost a little bit of a kind of a social media, almost like TikTok level following of patients who describe this inability to belch. And the pathophysiology of this is actually related to a failure of the upper esophageal sphincter to relax when the esophagus fills with air, when it should be instead venting. There's a large case series looking at UES Botox injection for this condition, but yet I still think within this realm, finding objective tools to actually make this diagnosis and help us triage who is actually good candidates for somewhat invasive endoscopic injection therapy versus those who maybe don't have pathologic disease as needed. And so that was what the key goal of this treatment was, looking at a manometric diagnosis of this retrograde cricopharyngeal dysfunction. And so this is an example of what this does look like on manometry, and this is actually a study from our center. But what we do here is to actually look at this is we do a manometry, actually an impedance manometry with a provocative challenge. And the challenge is actually a carbonated beverage, really trying to induce patients to belch, try to fill their stomach and esophagus with air. And in this patient who has this retrograde cricopharyngeal dysfunction, you can see that with this component here, there's LES relaxation, and the esophagus fills with air and actually pressurizes. However, the UES does not relax, and that, in essence, is what this disorder is related to. And so this abstract looked at a whole boatload of kind of clinical as well as manometric features to try to help differentiate patients at baseline, as well as looking at treatment responses. So they had a group of patients that actually underwent UES Botox injections, and so they looked at manometric changes in a follow-up manometry after UES Botox, and they also had a patient control group. And relatively small numbers within each subgroup here, but they found some kind of key factors, and at least started to provide some potential thresholds for using manometry as a tool to help identify these patients. And key here were really the UES pressure during that identified gas reflux events, and then even looking at measuring the duration of air entrapment following this carbonated beverage challenge, being much more prolonged in the baseline group of patients who had this RCPD. All right, and then they proposed this algorithm. Sorry, it's not displaying fantastically, but yeah, but to really help kind of use this thing, and people coming in with this symptomatic presentation, inability to belch, often presenting with some associated chest pain or other discomfort, but to really use these manometric tools to help identify maybe who be better candidates for a UVS Botox injection, and who may be someone else that you may want to monitor or treat in a different manner. All right, moving on, talk a little bit about Barrett's esophagus. There's a number of guidelines here that have come out. The most recent in the Barrett's space is actually from the ACG, identifying kind of a variety of factors, kind of into who to screen and how to survey reflux. One abstract that jumped out at me as being very interesting was from Joel Rubenstein, just down the road here, figuratively, looking at really trying to create a model to help improve utilization of some of the screening for Barrett's esophagus. Really recognizing that the Barrett's screening, just kind of identifying the correct patients can be a challenge. And certainly it's a high cost, and sometimes the benefits of that practice have not been really manifested as well as we'd like. But so using a large cohort from the VA, finding actually patients that had the firm outcome, looking at patients who had esophageal adenocarcinoma, also looking for patients who had gastric carcinoma, and then over 10 million control patients who didn't have cancer in the VA, and developed this machine learning model that used VA EMR and actually looked 1 to 5 years prior to their cancer diagnosis to help predict whether or not they would actually develop or have esophageal adenocarcinoma or gastric carcinoma detected. And obviously a lot of technical complexities to this study and the model and whatnot, but really key takeaway was that when they looked at this and they actually compared it with the published guidelines, this model outperformed for both esophageal adeno and gastric adenocarcinoma for this predictor. And really important here is that this isn't just detecting of Barrett's, but this is detecting the outcome that actually matters, and is those who actually develop cancer. And then when they looked at this, I think also more interesting is they looked at a variety of factors, looking at variable importance. And this was all based on just things available in the EHR, so demographic info, BMI, ethnicity, race, and some lab values. But they found actually age, race, sex being the key factors. And GERD and GERD symptoms were not actually among the most important factors here that predicted who will develop esophageal adenocarcinoma. And so thinking again about kind of where this falls, I mean, our most updated guidelines still use the presence of GERD symptoms as kind of the key criterion as to who to actually consider screening for Barrett's esophagus in. Whereas I think some of the models and some other emerging data are showing that symptoms may not really be the key driving factor. And there are other features that we may need to use to actually identify where endoscopy and endoscopic screening or other components of screening, especially when we start to look at non-endoscopic methods, may actually be of highest yield for patients for Barrett's esophagus. Certainly this study was thought-provoking and very interesting, but does need some additive validation in other cohorts. All right, and then finally, just kind of one abstract to leave on was an abstract from Dr. Reina Yadlapati at UCSD, really looking at kind of a tool to actually help with patients with extraesophageal reflux symptoms, so with the laryngopharyngeal reflux, or LPR. And what they had done is taken a sizable cohort of patients who underwent pH testing to actually use that as their gold standard for whether or not they had GERD. And so, using endoscopic criteria or positive pH testing, and then looked at a number of factors to actually help predict who with primary extraesophageal symptoms would end up having positive assessments, positive objective assessments for GERD. And they identified a number of factors here with both symptom, BMI, but also included the presence of hiatal hernia as being a risk factor. And what they did is they developed this score, and they called it this cough reflux weighted score, giving points, positive or negative, based on a variety of these factors. And this was really interesting, is that when they had a low score, fairly high sensitivity for actually detecting patients who did not have objective evidence of reflux, versus those who had a high score, particularly when the score was greater than 5, becoming quite specific for patients who would ultimately have positive pH testing. And so thinking back to some of these clinical practice updates and our algorithm for evaluating patients, overall these are complicated patients. They have symptoms with a large differential diagnosis that includes a lot of things outside the esophagus. And so certainly with added validation and testing and other cohorts still being needed, I think this certainly has some potential to help us really help triage which patients really do require GI evaluation and other patients that maybe we can triage a little more effectively kind of away from invasive endoscopic and esophageal testing and instead focus more on other non-GI, non-esophageal disorders. So with that, I'll conclude and thank you again for your attention.
Thank you so much, Rick and Dusty, for those excellent talks. We'll open it up to questions. So you can either come up to the mic or we can bring it to you if you raise a hand. And I'm happy to start with a question while you guys gather yours. So I find sometimes the most challenging patients are the most common ones that we see with regards to GERD. So for example, on Monday, I had a 39-year-old guy who came in and he's not refractory to PPI. So he had a positive pH study, like flagrantly positive, but he is just kind of percolating along, completely asymptomatic on omeprazole 20 milligrams a day. So given his age, and he was also white, and he carried a little weight, other than obviously risk factor modification, counseling on weight loss, do you feel okay letting them percolate along on a PPI given the safety of long-term PPIs? Or are those the patients that you would be more inclined to push towards an anti-reflux procedure given their cumulative lifetime risk of perhaps developing Barrett's?
Yeah. All right. Yeah, in that patient, PPI forever, I think, is a really viable option. I mean, one thing, the risk of Barrett's, Barrett's isn't a big deal, right? And even people with Barrett's will have a very low, yearly risk of actually developing cancer. And so, yeah, I think that, is that someone who would maybe require some screening over time and some degree of surveillance? Sure, but yeah, I think PPIs are safe. And, ultimately with a lot of this, especially the non-erosive reflux disease, this is a quality of life disorder. And so, yeah, often I see people, if it ain't broke, don't fix it. And yeah, 20 milligrams of omeprazole a day, I'd let that roll.
Brian?
Hi, Brian Ginnebaugh from Henry Ford. Thank you all for a wonderful talk. My question is for Dr. Carlson. Our relationship as gastroenterologists with ENT can be a little bit difficult at times, if I'm being polite about it. Recently saw a patient who is an opera singer, 28 years old. Obviously her voice is very important. Her only symptom, however, is globus, and she's been told all along that this is all secondary to GERD. Her otolaryngologist actually did order a manometry and a 24-hour pH impedance off of PPI, which was totally normal, with no evidence of non-acid reflux, belching, or any other disorder, and the acid exposure time was way less than 4%. I think it was 0. So she's been told all along that she's had GERD. She believes it. I asked her when she came off of her PPI, did anything change? She said no, and I'm really thinking that this is mostly globus. But my question to you is, I ordered a 96-hour Bravo off of PPI just to kind of slam the door on this altogether. But how do you go back to the otolaryngologist, and how have you had that relationship? Because it can be a little bit difficult.
Yeah, you hit on a really key component to that whole disease process. And it really is trying to get buy-in with your, kind of partners in other specialties there. And yeah, I'll remain polite as well. Because it can be a challenge. And if they, often I feel more often than not, you get those patients who kind of come in and, the jar has been figuratively tightened for us when they're told, oh, they had a laryngoscopy and it showed GERD. I was diagnosed with GERD because I had this, and these tests that, can be a little bit hard to kind of backtrack it. I think, falling back on the objective testing is key there. And using either the 24-hour and sometimes, even a truly negative 96-hour Bravo test, that's really profound in my mind. And I think if you look at that, you can pretty effectively slam the door on GERD. And and then it does require, I think, a little bit more of that relationship, coddling in some ways. I do send, dedicated messages to my ENT colleagues. I reach out to them directly just to try to have that conversation and discuss it through a little more, kind of personally. yeah, just try to help get everybody on the same page there. And yeah, and because there are, especially with the globus, the voice strain, some of those concerns, and a lot of other very effective techniques, and yeah, with GI focused cognitive behavioral therapy can still be very effective. Voice training, obviously, very very key, and at least in our center, I mean, our otolaryngologists are the ones who run our voice clinic, and so there's a lot of back and forth there, and trying to nurture that relationship. But yeah, I agree with you, it can be a challenge at times.
Thank you.
Okay, well, thank you for the excellent talks. Now that we talk about backtracking on diagnosis, it brings to mind two scenarios. The first one is those people with the ultra-short Barrett's, who, when they come to us and we look carefully, it's like, well, I wouldn't have diagnosed that person, but yeah, there's definitely like a 4 millimeter variation in the Z line. So how often, it's a question for everyone on the panel, like, do you guys tell them, hey, you don't have Barrett's, or I don't think this needs surveillance anymore? And the second question is, as compared to colon cancer, where at some point, low-risk polyps, after age 70, you tell them, you know what, that's it, you're done. Do you guys ever stop surveillance for Barrett's based on age alone?
Yeah, you want to take that one first, or either of you?
Go ahead.
Yeah, no, I agree that, yeah, those kind of, especially when those patients have been, multiple surveillance endoscopies over the year, and it's very difficult to even do a scope and not detect Barrett's on their 4 millimeters of irregular Z line, and then try to say, like, I think you were wrong and got a lot of unnecessary endoscopies. But I think it is also, just trying to kind of maybe work those around. And generally what I'm doing to try to keep everybody happy, I guess in that scenario, I think starting to space out some of those intervals. And even in some of the recent guidelines, it does, require, talk about going to like 5 years on those. And so what I've started to kind of do now is to at least think, okay, we're not just going to say no and stop, but let's space you out 5 years. And if at 5 years you're still normal, that, yeah, maybe we can, stop at that point. And, it's nice now that the guidelines have spaced that out and given us a little more kind of a leg to stand on in that regard. It also very much do use some of the other demographic risk factors in doing that. Particular, women that probably don't need it and aren't going to have high yield, so even be a little less aggressive there. And then, as far as stopping from an age standpoint, similar. I kind of look at it from a similar regard with colonoscopy. And really, I think even there, looking at just the rates of progression of non-dysplastic Barrett's. When you're looking at, a fraction of a % per year in someone who's 70, 75, we definitely have that discussion about what we're going to gain by doing endoscopic surveillance at that point. And again, falling back on some of the demographic risk factors, people who are very low risk, I have not had much of an issue or concern with kind of back off on some people, or at least just kind of leave it out there as like, let's have a discussion again when you're 75, see how you're doing health-wise, see where this maybe fits into your overall, kind of health benefits. It's kind of my approach at least.
Since moving, I've moved to a state where there are very few endoscopists, and a majority of these Barrett's patients that I'm now seeing, I meet for the first time in the endoscopy suite. They've been referred by their primary care provider. They're just continuing to send them every 3 years for an upper endoscopy. And I scratch my head. Some of these folks are in their 70s or older. They stopped their oral anticoagulant therapy for their EGD to screen them for their Barrett's dysplasia. And I think you have to look at the whole, you have to look at the whole picture. Do they have other comorbidities? Are they low risk for developing esophageal adenocarcinoma? And I usually take that opportunity in my endoscopy report. I'll put in my recommendations, stop Barrett's surveillance. Risk is outweighed, or risk outweighs the benefit, something of that nature. So I think it's a lot of case by case. I think there's some folks that deserve it still, regardless of their age, but I think many of them you could intervene with what you say in your endoscopy report, especially depending on where they're coming from.
Part of my ignorance, if I'm asking a question, because I really don't treat EOE, and I wasn't in the beginning of your talk, I had to step outside and make an emergency call to our leadership, Corewell Health, because of Beaumont being, what's the word you used? canceled in Southeast Michigan. So they had an emergency meeting and they decided to rename the hospital after your suggestion to Corewell Health William Beaumont University Hospital. So thank you for that. And so Beaumont is back on the map. So thank you. But all kidding aside, Dupixaban, and I really don't know this. Is there any data for using it in strictures, esophageal, strictures from EOE or not?
Yeah, so one of the exclusion criteria in the pivotal trial at this point was the severe narrow caliber esophagus. So from that standpoint, I'm not aware of any data yet published on those really severe phenotype of EOE. But otherwise, in this group, they didn't exclude patients for presence of stricture. They didn't exclude patients for previous dilation. And so strictures were in there. And they did show some improvement actually in objective endoscopic appearance with some strictures. And I'll tell you, and anecdotally, I have been kind of impressed that there are some patients who, you got dilated, say to 12 millimeters. We started them on dupilumab, and they come back, a couple months later, and that their esophageal caliber is 14 millimeters, 15 millimeters. I mean, it does seem like there's going to be some added benefit there, even from that fibrotic standpoint. So still kind of I think the hard data on that is still a little bit out, but I think, there's going to be some potential there that this medicine will actually help with resolving some of those fibrotic complications as well.
So you do it with dilation, or maybe start the initial dilation, put them on this, and then wait a couple months and see if they respond and rescope, and then.
Yeah, I mean, I think, I guess maybe if it wasn't clear from my approach in EOE, I think our kind of traditional approach has always been that you need some level of medical therapy or dietary therapy to control the underlying process. I mean, like every stricturing disease, if you don't control what's causing the stricture, you're just going to cycle back on yourself. But yet there is going to be also some component of mechanical therapy that's needed. And so, kind of depending on the degree of symptoms, the present treatment, I'm often, pretty aggressive in dilating EOE up front and even doing, often serial dilations, typically targeting a luminal diameter of their esophagus of at least 16 millimeters just to kind of lower that food impaction risk. And as part of that, when I'm doing follow-up maintenance just to assess for histologic responses for whatever type of therapy they're on, each of those histologic response assessments also carries that multi-purposing of another opportunity to do a dilation and treat them mechanically as well.
Thank you.
Of course.
Just to follow up to that question, because I know you guys have a hardy EOE population at Northwestern. For the patients that you do start on, Dupixent, because I can't say the generic name, but what are you doing with their PPI? And what is the plan for duration of therapy? Is there a plan for taper? Is it indefinite, like some of the agents we use for IBD, or what's your approach there?
Yeah, I think at this point it's really been as kind of an indefinite treatment option. I think we're kind of waiting to still see, long term. I mean, certainly the long term data looks fairly good, at least out to a year. I think we're kind of using it as people's maintenance therapy. PPI, it's one of those things that's, kind of similar approach to what we've done with elimination diet and topical steroid, kind of looking at whether or not there was some improvement. I think that, EOE is not a disease in a silo, and there always is going to be some degree of overlap with GERD. At least from what I'm looking at is I'm kind of looking at what degree of, symptomatic benefit did someone gain from a PPI? Were there other factors of reflux, whether it be erosive esophagitis or even some patients who have an EOE with hiatal hernia, a little more likely to leave them on PPI. But if we're looking at just a pure histologic outcome standpoint, if people haven't had another gain from PPI, those are people that I'll try to take off it and see if we can get histologic control on a single agent alone. And if we achieve our EOE outcomes, really looking at histologic control, endoscopic control, and very importantly, symptom control, then we don't need unnecessary agents.
Any other questions?